I'm Jason Schaff, publisher of the Santa Clarita Valley Business Journal. I'd like to welcome you to our healthcare roundtable, one of a series of roundtables that we have about every quarter here at the Business Journal. What we want to do here is just have a very informal conversation about healthcare issues, healthcare in the Santa Clarita Valley. I know that's a broad topic for an hour or hour and 15 minutes, but we sent questions ahead of time. I don't know if all of you guys got them, but just for a start, and it's not going to be one of those things where we're going to have to get through every single question and rush you to get through the 10 questions. No, it's a starting point. If you have questions, issues you want to bring up, please do. As I said, it's just a formal, casual conversation among friends, and with all a stake in the Santa Clarita Valley. So I'm going to be quiet and introduce our new Business Journal editor, business editor of the Signal, Steve Kiggins, and he will be leading the discussion, and I'll jump in if I get a question or something. But please interject each other. It's just a conversation, okay? So don't feel like you can't speak up. Okay. All right, very good. And again, my name is Steve Kiggins. I'm a week into my job now as business editor here. It's great to have you all here. Thank you so much for taking the time to be with us. And I know I'm looking forward to learning a lot as a new guy in town, so thank you. First, I just want to go around and make sure we all know each other, and if we could just do a quick intro, name, and your role with your company. I'd appreciate that. Go ahead, Chris.
Yeah, my name is Chris Regosa. I am a family physician with Kaiser Permanente, and I am in charge of the medical offices, Kaiser Permanente medical offices here in Santa Clarita on Turney Road.
Patrick Moody, I'm Director of Marketing, Public Relations, and Community Engagement for Henry Mayo Newhall Hospital.
Ina Gelfound, also new, not so new anymore, September, so I'm still new. Marketing manager for the Heritage Sierra Medical Group. We're new in town in terms of our new facilities right on the campus or offside the campus of Henry Mayo. We are in partnership with Henry Mayo, where we have an urgent care suite as well as a clinic suite. And we're here to make new friends.
I'm Roscoe Martyr. I'm a practicing OBGYN, and I'm also Vice President for Facey Medical Group. Facey's been around for about 90 years, but in Santa Clarita for about 30. I have not been here for all of those by any means. Yeah, we've been on Santa Clarita. We've got several offices throughout Copper Hill, Canyon Country, Valencia, and then right on the Henry Mayo campus as well. And that's where my office is there as well.
And Henry Mayo board member.
And Henry Mayo board member, and yeah.
Awesome. I'm Haley Widener. I'm Senior VP of Group Benefits at LBW Insurance. I also do management and human resources for our company. Mitzi Light is also on the board with Henry Mayo. And I am out there promoting insurance to Kaiser and Providence and to the carrier reps, and helping employees learn how to use the benefits when they come to visit Henry Mayo or Sierra Pacific and all the different carriers that are out there and hospitals.
All right, let's talk about something that's top of brain right now pretty much for everybody. And I was joking with Jason earlier that if you don't know somebody with the flu right now or flu-like symptoms, you probably don't know anybody. Can we talk a little bit about that and what's happening or what we're potentially learning from the flu situation that's going on right now?
Yeah, so I can speak to that. The flu this year, it hit remarkably hard and quite early. Last year we saw it peak around February, And this year, we just saw a huge influx of flu toward the tail end of December. Certainly, we're right in the middle of it now. And what's interesting about it is really just the severity of the flu virus. I think this year the vaccination is effective in about 10 to 30% of population. Typically, it's effective in a successful campaign is about 50 or 60% of matching with the strain, correct strain. And this year it's a little less. I think there was a mutation in one of the genotypes of one of the viruses, but so it's still really powerful. It's causing a lot of a huge influx in volume we're seeing, and those that are really susceptible, the elderly, the children, those with immunocompromised states are really bearing the brunt of this spike for sure. So what we're doing at Kaiser Permanente is we've adequately staffed up. We realize that it's upon us right now, and we manned up. We brought all our resources that we could to have ready to go so that we can take care of the population. And interestingly, this past weekend we did see a little decrease in the volume. So I think we're getting ahead of it. Keeping my fingers crossed, obviously, but it's pretty bad out there.
Yeah, it's pretty frustrating, like you said, that the vaccine's not nearly as effective as we were hoping. I think those were the older numbers, the 10 to 30. I don't think it's even that much. I was talking to one of the intensivists at lunch today. He said, yeah, they just missed on this one in a lot of ways, and so everybody is getting hit. My daughter was especially upset because she got the flu vaccine, was telling all her friends they needed to get it, and then she came down sick a day or so ago, so she doesn't want to tell anyone, so don't let that out.
Well,
she's hoping that science thing will work for her.
One of the things that I'm seeing is those that are vaccinated tend to have, they're like primed. Their immune system is somewhat primed, so you may get the flu, but you tend to not have the severity of illness. So I think there's still value in getting vaccinated. There's no question. Whether it protects you fully against this new strain, it's still, there's still value.
So what you're saying is, because I was just at the pharmacy yesterday and the pharmacist said to this person in line, don't bother, so the person left. So what you're saying is that it's still a good idea to go and have the shot, correct?
Of course, yeah. I mean, this is, you're turning down such an intervention that potentially could save your life, even though it is not as effective as in previous years. I think there's still a lot of value in getting
I have
vaccinated.
2 questions.
Yeah.
Are we seeing the senior population and the younger population particularly affected, or is it just across the board at all age groups?
Across the board, but you have to remember that those that are in the senior population and those that are quite young, they tend to have the higher severity of illness. So those patients will tend to be hospitalized, that will have the respiratory complications like pneumonia, and just have more trouble with it.
So that means to me that you and I types have to do a better job at educating and making sure that the general public sees some value and still takes care. It's not all that hopeless, right?
Yeah, of course.
Is there any particular danger for pregnant women?
Yeah, it's very much, they fit into that high-risk category as well because of their altered immune response. So the senior population tends to not be able to build up the same type of response. The younger population doesn't have the antibody history that you and I have had by exposing ourselves to years and years of flu over the years. But the pregnant population also, they have a inherent kind of decreased immune response a lot of times, and so yeah, they're very much recommended. We've been pushing that very hard in our clinic to get vaccinated for it, to try and help out with that.
What was the flu like 7 or 8 years ago that pregnant women were really?
There was the swine flu virus.
Yeah.
Is that what it was?
H1N1. No, H1N1.
H1N1.
H1N1?
So if somebody's already been sick, so should they still go and have that shot after the fact now?
I would recommend it. I think there's still value in getting the vaccine. I mean, we might be right in the middle of it, and it takes 2 weeks or so to get fully to have your immune system ready to go after the vaccination. But we know that the flu season can go on for several months.
So as a non-clinical person, when they develop the flu vaccine annually, and is there research that guides them as to what kind of strain we're dealing with? And is the vaccine that's developed for more than one strain, historic types
Yes.
as well as, yes?
Yes.
To all of that?
They take into account what we're seeing overseas, what we're seeing in other times of the year, and maybe on the southern hemisphere, and to try and match it to the strains that are currently most virulent. So, yeah,
That's
but
why it makes
sometimes you
sense to
can't,
get-
you can't get it right, and then the flu virus does mutate quite readily.
It is an educated guess,
Yeah.
for sure. You're really trying to predict where it's gonna be in a few months, because it takes several months to develop. Even once you kind of pick where you're gonna go, you've gotta grow it, to make it available, and so you do have to decide several months in advance.
What, any of your facilities having to care for people in weird places that you ordinarily, because of overflow or taking any type of, are you using
Sure.
hallways or something, or?
That's
You know what I'm
always,
saying?
yeah, that always happens. Interestingly, again, with our organization at Kaiser Permanente, we actually had, flu is something that we generally is treated by primary care physicians or OB-GYNs, emergency room physicians, urgent care doctors. But we were speaking whether or not if it's so severe that do we need to enlist the help of our specialists to help out. I mean, a infectious disease doctor obviously would make sense, rheumatologist, anybody who on board to help, just because this is just basic, it really is basic doctoring at some point,
Right.
just understanding how to treat flu. And we all went through it at some point.
A lot of it's supportive, lots of fluids, the same thing that we
Yeah.
would do any time for a virus, so.
So while the
Fluids.
venues may be similar, on our end, we're looking at, do we staff up with providers that don't necessarily, routinely see these types of conditions?
Are you seeing greater numbers?
Of flu?
Yeah,
Oh.
greater than the year before, greater
Yes,
than the year.
there's no question. This year is far and above. It's way bigger, way greater.
And going back to what we were just talking about as far as how you build a flu vaccine from one year to another. So how does the information that you collect this year go into what we think about next year potentially looking like? Or does it follow any sort of guideline? I don't know what it does.
I probably wouldn't be that qualified to speak on the specifics on how the immunology, really this is all what that's about. But I could tell you they do take into account what happened in the previous year, what's happening now in other parts of the world, and to try and make the best educated guess so that we have a good shot at getting it right.
Okay.
Yeah.
Yeah, I think to your venue question, I think Patrick gets to answer that one, because at Henry Mayo, I know we've got one of the cafeteria rooms, we're now seeing patients
Oh,
because
that's
of the
right, yeah.
overflow
Yeah.
from
Yeah.
the ER.
Really?
So, yeah, one of the smaller rooms in the cafeteria actually kind of abuts to the ER, so.
And we do have a contingency plan, which we have not had to deploy, but if we have to set up a tent outside the ED and triage patients there. Our waiting room's getting really crowded, but we haven't had to do that yet.
Okay.
But we are prepared to do that if we have to.
And we could see flu season go for how much longer? I mean,
It's only
generally.
early
if you-
January.
I know it is. I
Yeah.
mean, it's.
It can go
Usually peaks in
March.
February, so
Does it?
we've still got another couple of months.
Mhm.
So last year we saw it peaked in February, and then it started tailing off in late April, early May is when we started seeing the volumes go down.
Is it, I know I'm not supposed to be asking the question, I'm just curious. Is it uncommon for someone who's gotten it to get a different strain later the same season?
That I wouldn't know, but whether or not they get a different strain. I know that there are. I'm just speaking out of personal experience. I've been vaccinated, and I caught something that I felt like was a flu. It was classic flu, but it was done in like 2 or 3 days. So I don't know, and I'm seeing a ton of flu patients. I would think that I would be exposed, and
Yeah.
certainly my health is, feeling pretty good right now.
Well, there are multiple variants, and so I think to your point, yes, that you do have sort of a partial immunity, if you will, but there are so many variances that it may not be enough, and you may get hit, you may not.
Mm-hmm.
You know, always back to hand washing and trying to cover when
Right.
you cough and sneeze and all that sort of stuff, and try not to share your food, which for us at this table, not a big deal. For college students, I don't know. It's just picking off each
Little
other's
kids
plates
too.
all the time.
And little kids
All
too,
the
sure.
time.
And I think the last thing that is important since we're on the topic of flu and prevention, sleep is
Right.
one of the number one determinants of how strong your immune system is. So if you get regular sleep and you take care of yourself, get diet, exercise, that goes a long way at bouncing back from these types of illnesses and in many ways preventing it.
Absolutely.
I never heard that before.
Yeah.
Wow. I mean, I didn't know it was that fundamental. I knew it was important overall. But I didn't
your
know
immune
for-
system repairs itself and primes itself when you're sleeping.
Huh.
And so if you're not sleeping, you're constantly in the stress state.
That's right.
Yeah.
And so it paralyzes your immune system.
It's just tough to find enough time to sleep.
Yeah, you gotta find it.
Obviously, flu season's been really tough. Not a disaster. Want to talk a little bit about, we just got through a fire season, obviously. California, we're going to talk about earthquakes. How are you and your facilities prepared for disaster, for emergency situations? What pieces are already in place where you could care for people in a situation such as that?
I can start. We train for that. We do an exercise at least once a year. We just did one. It was a county-wide exercise in which we participated. We set up a number of tents outside the ED, triage patients. We work with the sheriff's department, the fire department. The scenario of this last one was a overturned bus at the 210 and the 5, and then there were terrorists on the bus. And, I mean, it was like the scenario that kind of kept going, who got out after the bus turned over and started shooting people. So you got accident victims and gunshot victims and everything. And so it was a day-long training that involved pretty much everyone in the hospital to set up the tents, make sure the information is going back and forth about how many patients we have and so on and so forth. So we train pretty seriously for that at least once or twice a year. So I feel like we're pretty well prepared, at least our hospital. And again, we work with a number of other groups and we do that.
Right, there's a community organization called Community Emergency Response Teams, CERT, and they have team leads who go through extensive training, not just on the appointed disaster day practicals, but that's very comforting to know that, and I just attended at Henry Mayo, your staff is fabulous there, they did a Stop the Bleed,
Oh, yeah, yeah.
which was wonderful. It's open to the public at no charge, and they have, for just these cases of terrible traumas and horrible disasters, how residents without clinical background can actually save patients' lives. Knowing where and how to use a tourniquet, how to create one, where to put the tourniquets. I found it phenomenal.
I could tell you that, we at Kaiser Permanente have, routinely do these drills and that Patrick was alluding to. It's about planning, education, having the right materials, creating the right coalitions between, organizations, other healthcare organizations, law enforcement, emergency response. It was interesting, we just had the fires here in Santa Clarita just a month ago, and we treated that as a disaster scenario where we had command centers, we had every 3-hour phone calls that everybody chimed into, understood how we were doing. We actually had smoke from the Silmar fire blow right over getting close to one of our medical office buildings, and we had to shut it down. And we had, patients that were going to seek care. So what were we going to do with these patients? How were we going to still deliver? So that whole scene was it was a disaster in the works, and so we had a chance to really try it out and see how, not just try it out, but really live it and then breathe it and be part of it, figure solution, problem solve. Where were our resources? Where do we put our our resources that we currently have? Fortunately, we came through okay, but.
That's actually, I don't know if you had the same issue, because we actually called the code for that too.
Yeah.
But the issue for us was whether our staff could get into work
Yeah.
or whether they felt they had to go home. So we need to make sure that we were adequate staff.
That was one of our situations as well. We had, because the freeways were closed.
Yeah, we dealt with
Right.
that as
Yeah.
a medical office as well.
Yeah.
Yeah, we ended up closing our office one of
Did
those
you?
days because the electricity went out.
Right.
Oh, that's right,
We did
that's
the
right, yeah.
computers and.
Well, the fire
nothing.
was right by LBW.
Right.
Oh, that's
It
right.
was right, I mean, we're all standing in chairs watching this hill go,
Yeah.
Wow.
and then, right on down into the canyon. So, yeah, it was scary. Yeah, but we all left. We all,
You were
That was a
able to
good
get
thing
out.
to do, I think.
well, because it was windy, and
Yeah.
you're right.
In a matter of minutes.
The computers were going crazy. You
Yeah.
finally get back on, and then bam.
Yeah.
It would,
Yeah, I live in that neighborhood, and I was actually packing stuff to.
There were people,
To
they were
evacuate.
asking people to leave.
And it never got to that in my particular neighborhood, but it was like,
Mhm.
whoa, it happens really fast.
Mhm.
You gotta know what to do.
Mhm.
Let's switch gears and talk a little bit about each of your own individual companies and how you're growing, where you're growing as the Santa Clarita Valley continues to grow. Are there some new things that are happening? What can you share about kind of that overall vision and mission statement moving forward?
Sure, I can start. You want-
No,
you can start?
no, I don't want to start.
Okay. Well, we're really excited. We are opening up a brand new medical office building, just two doors down from our current medical office building. We're bringing specialty care to Santa Clarita, at Kaiser Permanente Specialty Care. So we are, which means we're bringing orthopedics. We're going to have a surgery center, outpatient procedure suites. We are going to have cardiologists, the whole gamut of specialty services, in addition to our current medical office building that has all the primary care services. So we really thought it was going to be really important to to provide that service to our members here in Santa Clarita. So that's how we're growing, and that's just around the corner for us. That's going to happen in 2 months, in March. Santa Clarita is very, very important to us in my organization. Not only do we build buildings and we bring specialties, we also are very involved with community benefit campaigns, and I think I know many people in this room just as well. We give every year. I think this year we gave like over $60,000 in grants to the community. So we really value what we provide to Santa Clarita and Santa Clarita residents, and so we're excited about our new offering, and it's just opening up around the corner. We're also moving our urgent care from our existing building to the new building, so that's going to be it's going to be much bigger, and we're going to be able to provide quite a bit more services.
Which helps me out a lot because, I sell Kaiser to the community, including my own company. We put Kaiser in, and it's good to have a place for my employees to go and not have to go to the valley when they need stuff. So our representatives gave us flyers about that, and we were all very excited when they were opening up that new facility.
It'd be nice to have that bigger urgent care right now, wouldn't it?
Oh man, I know. We're just yeah.
It'll open up right after flu season.
Yeah.
Perfect.
Yeah.
So, yeah, our urgent care underwent some change over the last few months as well. We had a lot of staffing issues about 6 months ago, and Kaiser stole half our urgent care docs, but we've been able to replace them now pretty well, and so it's a good place to work. But we've replaced them, and so we'll be opening up fully. I think we're down 1 day a week up here in Valencia. On Wednesdays still, but come February 1st we should be up to full speed 7 days a week. And ours is right on the corner of Valencia and McBean there, so they have a very busy urgent care. Summit Surgery Center is right there where our specialists do a fair amount of work as well. I know Kaiser, the ophthalmologists, do a fair amount of work there as well. So, but yeah, we're looking. We've renovated a little bit in the time frame and been able to improve that, and so very happy to have that up to full speed again. In the meantime, we've partnered with XER, XER. They're in Stevenson Ranch now, and we're building out a new office building starting in Canyon Country. So our old one, our lease was up, and it was time to switch venues there as well. So we'll be building a brand new, still in process of building a new medical office building, just going out the 14th. So in that we'll have an urgent care as well, and that'll be staffed. We contract with XER to staff that one for us, but we'll be staying at our current one there in Valencia. So.
Is there a timetable on the new?
I believe it's next summer we look to be opening. Okay. So yeah, we broke ground on that last summer. And I remember it was summer because it was hot.
Yeah. It gets hot here.
But yeah, no, we'll be looking for that to open up, and we're very excited about that as well. We're expanding our offices in the Valencia building as well. So within that building, you don't see anything on the outside, but happy to add another few primary care physicians there as well.
How about at Henry Mayo?
So, you know, we're a community hospital, so we kind of see our role as trying to identify areas in the community that are not served, and then if we can do it, Dr. Martyr knows the calculations that have to go into launching new services, then we try to launch services to meet those needs. A couple examples are, we now have hyperbaric treatment in our wound care clinic. There wasn't hyperbaric treatment here before for wound care. And then we're expanding our cardiovascular services. We're offering expanded electrophysiology services for people with AFib. And we didn't have that before. So those are a couple examples of how and there was, for people with that condition, they had to travel a long ways to be trained. That could be a life-changing treatment. So we just have to look at those kind of unmet needs as best we can, try to meet them.
Yeah, Henry Mayo's been very successful, I think, with their cardiovascular program just from the get-go. It was originally set up as just being an outpatient kind of cardiovascular lab, and it's morphed into open heart. Just by state regulations, it kind of had to do that. But I think the numbers in the STEMI Center have been exceptional as far as matching up with any other cardiovascular program in the area. So adding on to that with the electrophysiology, I think, is a natural growth for it.
I'm so glad to hear about the hyperbarics. I had an example of this month, well, last month, December. My daughter had 7 hours of surgery. It was the 4th surgery that she had. And the new surgery, actually my daughter-in-law came up with the idea of hyperbarics. And 27 years ago, I installed the first hyperbaric chamber in New Jersey at a coastal hospital for the Benz patients. At that point, it wasn't really embraced for wound care and other things. It had a bad rap due to some celebrity use of the hyperbaric chamber. Actually, it was Michael Jackson who was treating his vitiligo. And actually, they do have statistical information that it does help. Anyway, the best thing is that my kid came out of 7 hours of surgery and never looked like she was in surgery. 5 days of hyperbarics, an hour and a half each day. And she had 3 surgical sites. She had breast reconstruction from a bilateral mastectomy, and she had fat grafting done from her back and other areas of her body. So we were prepared, and we were told that she was going to look like she'd been through a train wreck. Long story short, the next day, she was up and about, she did very well. Next day, she went to an hour and a half of hyperbarics, 5 days straight, no pain, minimal bruising, out and partied with us. I have the chills. Saturday night, the following, she had surgery on the Friday before.
Wow.
And I know the difference because she had 3 other surgeries prior without that. Now the physicians are recommending that this be a part of the protocol as an elective for those people who can afford it. It's medical grade hyperbarics, which is different than any of these oxygen therapies that sometimes get confused and used for good devices, but they're not as accepted, and then it sometimes gives us problems getting hyperbarics all lumped into one. So that's great to hear that you've got that here. That's fabulous. We're Heritage Sierra Medical Group. It was formerly known as Sierra Medical. We're part of Heritage Provider Network that owns 10 medical practices. And the Santa Clarita office was up and running, but we renovated a suite. It's a growing community, and we welcome, and you make us better, Facey, and so do you, Kaiser. And we love being right on the campus of Henry Mayo. We need, the community obviously needs all of us. So we too enlarged our services. And while there's an urgent care right on the Henry Mayo campus, we have urgent care facilities as well. That means it gives folks who have a comfort with their doctors using a medical record and telemedicine so they can follow all their disease conditions and medication conditions right within the facilities. So we're having a grand opening on the 30th, and you're all invited, and the chamber has given us a list, and I'm brand new to the area and my job, so I'm just having a ball learning. I'm old hat to the business and helped and did a lot of this stuff in New Jersey and in San Diego, from where I resided for 12 years with Scripps. But here, I'm only here a year, and I'm new to my job since September. So I'm meeting all of you, and I'm having just a ball. And I welcome any input that you can give us, and we hope to be worthy, healthy competitors, but good partners in medicine, helping the Santa Clarita community. That's our aim.
I'll come hang out with you on the 30th.
Okay, I appreciate that. I'm making, time is so short, we're not getting printed invitations, although my corporate's supposed to be working. We're doing the email blasts and phone calls. Please take this as a personal invite and a request that will you let me buy you a drink at our facilities, starting at 4 o'clock. And Dr. Merkin, our owner, is really anxious to meet folks like you. Because he is going to be present and make just a few remarks. And we're going to use the Chamber's ribbon cutting services. So we should have a good time. So please join us.
Haley, what's going on over at LBW that's new this year?
Well, we're just trying to work with the groups, getting people insured. The individual marketplace is sort of kind of tanking. I'm sure that everybody knows that Anthem pulled out of the individual marketplace in Southern California. So we had a lot of work to do to get people insured elsewhere. And quite frankly, there's only really Kaiser, HealthNet, and Aetna on PPO anyway. And so it was a little bit challenging because, you know, there's a deadline and then there's a group. The group was renewing at the same time. So we are just trying to get everybody into a very good place and educate them on where they need to go. It's really nice to know that there's going to be some more urgent care here, because it has been a little bit of a dilemma on my front when I've got clients calling saying we've got nowhere to go. And I know that
I've heard that.
there was some closure, and it was very complicated, because when I'm out there saying, oh, you know, here's your plan and here's what you do, and by the way, only use urgent care, only go to emergency if it's a true emergency. It was a problem. So I'm glad to know that there's going to be more options for us to communicate to the people, because I am talking to the people that live here that are using, whether it's Anthem or Kaiser or Blue Shield. I'm the one and my staff trying to explain to them where to go. So I'm really happy to hear that we're opening and that we're having another place to go. But I'm the forefront, so I'm out there, you know, talking to all the people that are coming to your facilities.
Do you mind if I ask her a question?
You go right ahead.
SEP, which is the special enrollment period that was granted for LA County, of which of course we're a part, having to do with the closures of our roads and businesses during the critical last 2 weeks of open enrollment, which was the normal open enrollment period. Are you doing anything with those folks?
So we've got most everybody squared away at this point. Even some of the people that have delayed, I can use I was talking to you about it. My husband's partner, wife, called me at the 11th hour. I don't have insurance come January. That was like December 29th. So on the Saturday, I'm trying to get them all insurance, over the weekend. So for the most part, we've taken care of that. We've gotten people where they need to go. If not, then there's still that period, especially for the burn area folks.
Right.
So we're working with them. A lot of them, we're very proactive. We are calling people immediately. So in our department, we immediately took the list of people that we know that we wrote Anthem Blue Cross individual policies
Sure.
for, after, ACA, and if we had any prior, we were automatically calling them to make sure that we were not in that, like, oh no, what are we gonna do at the 11th hour bucket? So our staff had already had that kind of squared away. But we do have some people calling that are out there that don't have representation that are calling at the 11th hour, and we're helping them get where they need to go. So yes, we are helping them. Yeah.
Thank you.
Yeah, and we were talking, before we started, just about individual mandate. We were talking about group coverage. Touch on that a little bit on both of those points, because all of that has been in the news, especially individual mandates been talked about, oh, it's gone, but it's not really gone yet.
Well, so the individual mandate is supposed to be gone. It's been said in the bill, and it's been talked about on TV. But I'm part of NAHU, LAHU, and KAHU, which is an Associated Underwriters Association, and we still don't, nothing really has been sent out yet that it's truly, like, there's a drop dead date that says, okay, the mandate is truly lifted so you can go get rid of your insurance. So that's still kind of looming out there. And then going back to my husband for a moment, they have an opportunity to put group medical insurance there, which I'm hoping that they'll do, because the individual marketplace doesn't have as many doctors and choices as group insurance. So, and all the perks that come along with it, pre-tax deductions, company write-off, the fact that there's just so much more to offer than in the individual marketplace. So I'm hoping that, we're gonna be writing that so that my husband has a better insurance program. So, and the carriers are actually tweaking what they're offering, making it even more complicated. So you're still getting your increases. We're still paying more out there and basically getting a lot less. So group insurance is really the way to go, whether you're small group or large group. So
Yeah, the individual mandate's probably one example of kind of the uncertainty that we're all facing in healthcare moving forward. We hear, the ACA, what's going to happen with that? Tried to repeal, didn't work. How are healthcare companies able to plan and prepare for the future, or has the uncertainty impeded that in any way? Kind of talk to me about that a little bit.
Certainly, uncertainty is not the best friend of any business. We certainly feel it in our healthcare industry. Speaking for my organization, we tend to adapt well to these types of challenges that come up. So we, while it's uncertain, we have contingencies in place, and we try and work with the best possible offerings that are out there. There's no question. You listen. There's the uncertainty in the market. With all the legislative challenges that are coming forth. What we do know is that the best solution, at least in our opinion, is to have the greatest number of people have access to medical care, really. And that is however that could be accomplished. I mean, there's many different ways to make that happen, but that we know is the most workable solution. And for the longest time, it's been group coverage, right, and on commercial lines, and that's still half of Americans still get their insurance through these group coverage and through commercial lines of just through their workplace. and that is traditionally still is going well, you know. And so when we hear a lot of these different, you know, challenges that we're seeing coming through, single payer, you hear, especially here in California, it's to us, it seems like it might be an attempt to overhaul a system that potentially is not all broken. Do you know what I mean? It's just, we have some areas are working really well, others not, and you know, we just try and position ourselves well so that we can adapt to these challenges.
Yeah, I think that the individual mandate makes sense from a insurance point of view. I mean, if you're providing insurance, you need a lot of people to have the insurance so that if you can access it and make use of it. But ultimately, I agree that the more people that have access, more people that have insurance of some sort, so they're actually willing to access healthcare before they get deeply sick, makes a lot more sense than waiting till they're almost dead to then show up, because they just have to at that point. It's much more expensive, it's much more costly to the patient, it's much more costly to everybody in the system. And so it works out for everybody a lot better if they have some insurance or some means to access healthcare early on. More of the, like our vaccine talk earlier, if you can get the vaccine, it's relatively inexpensive. If you have to go to the ER and be treated for 3 days for, you know, pneumonia and all the other parts that go with the influenza, much more expensive. And so being able to access that care at some level, whether it's with Kaiser, whether it's through Blue Cross, Blue Shield, Medi-Cal, whatever the venue is, but somehow you need to be able to access it
Well,
early
that was
on.
the reason for the individual mandate, because you cannot have insurance for all without having all young, healthy, well-being people in an insurance pool. Otherwise, insurance becomes prohibitive, which is exactly what happened.
And here's the thing, originally when they tried to repeal this, before, it was said that they weren't going to do it because there were the mandate, individual, group, and large group, was intertwined. So if you get rid of the individual mandate, and right now there is a stipulation that open enrollment to get an individual plan is between November and December for January, and you remove the individual mandate, and let's say all of you guys get rid of your insurance, and then 2 months from now you're sick. Well, okay, so what happens with you? Are
go
you
to
going
emergency
to
room.
re-enroll in the insurance? Because you can't go in and out and in and out and in and out of insurance.
That's right.
It affects the, you know,
Well, the risk
The
pool,
selection,
the,
yes.
the risk pool changes,
So,
but you
right.
can't, it's impossible to manage.
yes.
It's no easy answer. The problem is, look, we're 4 people, 5 people, 7 people, 20, 100. Do you know how many years they're sitting up there with good brains? And I believe partisanism, aside, there are enough people, doctors, good healthcare professionals, who want to find some workable solution without being socialized, quote that bad word. But the problem and how it affects providers and deliverers, Henry Mayo, the doctor, my medical group, it's very serious. And what all of this confusion and in and out and try to repeal and not repeal, and we're partially doing this and then we're taking it has caused such concern in the marketplace for the consumer that this year all the brokers that I've interacted with, because we give venue space to brokers, for their events so that they don't have to spend money for meeting rooms, etc. And we try to be as helpful in partnering with them to access as many people, let them sell every product, let them sell Kaiser, let them sell Blue Cross, let them sell whatever. We just want everybody insured. And folks just hung back. That's why you had this last minute Annie, because they're so afraid and they don't know and they're unsure. And seniors, forget it. If they had Medicare coverage, even though Medicare Advantage is the commercial plans offered by for Medicare, you know what that is, right? The difference traditional Medicare and Medicare Advantage have enriched those programs beautifully. They're now giving vision, hearing aid, dental, wellness, transportation visits, credits for seniors. Just, they don't want to change. You know, human beings don't like change to begin with, but when so much is going on and there's so much noise, they are so uncomfortable that every broker, I've dealt with about 15, 20 of them in the last 4 months, they told me the fall off of attendance to those events was so significant, it only said to them that everybody was staying put, that even though there were richer benefits and they could access insurance for less premiums, folks were just real skeptical about making change.
Yeah, I would say that in my industry, most people were really not wanting to move after all the moving that we've done over the last 2 or 3 years.
Scared.
A lot of people stayed, but in the individual marketplace, there was nothing you could do because the anthem was gone, so that was something that needed to be done.
Right.
But most people wanted to stay, you know, where they were, or they wanted to add, which I added a lot of Kaiser
Everybody told me
group.
that. Right.
Group. So if you have
Or
Blue Shield
supplementals.
and Kaiser,
Right.
you know, I'm talking about in the group arena.
CVS and Aetna, this could be a historical merger in the healthcare industry. Does that lend to any further uncertainty about, you know, what might happen? You know, if you know, there's talk about, you know, their minute clinics could replace, you know, your doctor visits. You know, the cost of prescriptions could go down, et cetera, et cetera. Is there some thought about how that could play into the future if that deal does in fact go through?
So I did a little bit of investigating on that once it transpired, and then of course, you know, I did a little bit more since I knew I was going to be coming here and you were going to ask that question. So it seems to me in the reading, even though nothing is set in stone, that if what happens, it would almost be like Kaiser and Aetna could be like competing. They wouldn't, because you have a far superior online system, but Aetna, and Aetna's personally not one of my favorite carriers, especially in the small group arena, and they'd have to change all their plans and redo their rating structure to get people to enroll. But it seems to me like they would be having this, what I'm reading and hearing and talking to people about is keeping their drug benefit now, because CVS and Aetna would be one. It'd be like going to Kaiser. When you get a prescription at Kaiser, you go to the Kaiser pharmacy. So if Aetna does this and they put it together the way they're thinking with the Minute Clinic, then Aetna members would have to go to CVS to get their pharmacy, to get their prescription filled. But that doesn't mean that it's going to be the best place for the consumer, because even me on Blue Shield or HealthNet, Ralph's program, I get a medication that would be $50 for $30. But with Aetna, what I'm reading and understanding is they wouldn't have that option. It would be captive, which could be good or bad. It could, what they're saying, it could reduce the cost of the medication, or they could keep it captive and make it more, and the Aetna member wouldn't have a choice. So that's what I was kind of reading and getting, that it could be kind of like a...
Guess what? If the Aetna member doesn't get the choice and that captive program is too expensive, buy Aetna, because they can't afford to keep that up. It'll take 1 or 2 prescription refills, and that'll happen.
So we have 300 clients, group clients, and I think we have 5 that are actually with Aetna. 2 large and 3 small groups. So Aetna has changed a lot of things in their benefit lineup, and with that, it's not that I'm against Aetna, but if I'm going to have somebody spend $300 or $400, I'm going to compare all the carriers so that the employee is going to get the best first dollar benefit for that same $300, $400. And while we do have people that love Aetna, their premiums are high, and what they're offering isn't they did some things that they tweaked it and it's not working out.
Not
When
for
you
the
look at
Medicare
it,
Advantage
yeah.
drug plan
So,
is good.
so, yeah, and then there is the whole minute clinic. So what they would do, what my understanding is that they're going to try to eliminate seeing your provider,
Mhm.
right? So, and not that that's a bad thing, because we've got teledoc now. Everybody's gone to the teledoc. Your kid's sick with the ear infection, you can do the teledoc and not have to go and see a doctor, right? Which is nice. But I don't know if, you want to be going to CVS for your medical care. I mean, I guess they're going to consider staffing it with some doctors or maybe some physicians. And so that's like up in the air.
So I think the big picture, and I think you're touching on it just now, is the collaboration between these titans of industry in a way to transform how healthcare is delivered. Right now, before this traditional, I am sick, I'm going to my doctor's office, and that's where I go. And after that, I go to a pharmacy. Now it's how do we integrate into the lives of our patients? Where are they going to buy their groceries, or where are they going? Can we play in that space too? And so the CVS Aetna merger with their clinics, that's a way to do it. I know that with Kaiser Permanente, we are partnering with Target. So we've pointed and within a few years we'll have over 30 of our clinics in Target stores. We've already opened up several of them already, and that's an example of how we are trying to expand and not necessarily replace the traditional healthcare model, but really go after the areas where our patients live, work, and play. And if we can be in that space where they conduct their daily lives, it's just another access point to our healthcare system. And to do it in a way that's, specifically with our organization, to do it in a way that's integrated with our healthcare delivery system, our technology, which we use, where we not only do urgent care there, we can do primary care, preventive services. So again, another example of where healthcare is being transformed. And I think it goes to another question: is how do we transform our industry and not be afraid of it, but embrace it and disrupt it and play in that space and try new things. And I think the Aetna CVS merger, obviously, if it goes through, will be a perfect example of that. Our collaboration with Target is another example of playing in that space.
Will your online access, because I pride in telling people that Kaiser is the leader when it comes to that online. Reach your doctor, see your test, make the phone call, make an appointment. Will your system reach Target?
Yes.
See,
Yes.
Aetna, it doesn't have that. And
Yet.
one of the, none of them really do have
No,
that.
but that's part of the
Right.
thing.
But one of the things that one of the doctors said in the article that I read, a couple of them, is that the doctor would then lose what's happening with their patient when they're going to
That's not true.
that's what he was saying. Yeah.
Well, certainly that wouldn't happen with us because we're
connected.
integrated and we see what's going on. And I should mention that this isn't just a service that we are providing for our Kaiser Permanente members. We will see non-Kaiser Permanente members at these clinics as well. And we create some fee structures to allow for that.
Has that already happened?
Yes.
So you're already in some Targets?
Yes. None around here yet.
I was going to say, because
None
I'm
around
pretty
here,
good
but it's San Diego, Orange County, and
Okay.
I think we've opened at least 4, maybe in the vicinity of 7, but our plan is to open up 30.
So you're in
within
Orange County. You're in.
Orange County and San Diego so far,
Okay.
and I think the Inland Empire.
Do you have
And
any
so-
idea when it's going to come to San Fernando and LA?
I don't.
Okay.
I can look that up though.
Okay.
An alternative to the kinds of medicine delivery that you're talking about is concierge medicine, because there will be those people who don't want to give up seeing their physicians who want a more intimate. There is that group of soccer moms and folks that need and like to play and shop and do everything under one roof. It's convenience, that's the ugly American. We want that, and there's a huge marketplace for that. But for that other segment of population who is either old school, doesn't want to engage or play in that workspace, there is concierge medicine. 2 roads for concierge medicine. Originally thought to be for an upper class group of people who wanted to maintain a relationship, have that specialized service whenever they called their doc, they were going to get to see him. And they prepaid an agreed upon amount between the physician and that patient up front. Generally, that's what concierge medicine means. The other more broad-based concierge medicine is capitated medicine to that medical group because it's prepaid medical care at full risk. So you're taking, that means when that medical delivery system, my office, has a primary care doctor, we want to keep that patient as healthy and as vital and the user of less health services than any other patient population because we get paid a fixed dollar amount for those capitated patients that are in our practice. So if we have to put a patient in the hospital, that comes out of the money that they prepaid us. If we have to have a patient who consumes a tremendous amount of health services and we don't have other healthy programs to support that, so we're calling and starting as a new idea, concierge medicine for the general public. It's not just concierge medicine for the elite. And that's what we hope to also introduce and make sure that these patients have access. That's the key. So in our primary care, we do have wound care, dermatology, we have special small procedure units. And so those kinds of services that otherwise you'd have to go and schedule to see specialists. The other thing that you were talking about, bringing all of that, that's so important. Currently we're offering lab, x-ray, and EKG so that members or people who visit their primary care doctor to our practice do not have to make a specialist with a specialty appointment with a cardiologist or go to have their lab drawn elsewhere.
Are you talking about HMO?
Yes.
How are you going to do that with the medical group?
I beg your pardon?
How will you do that with the medical group?
Because we have our own network, and we have a complete network of 181 doctors.
Oh, okay, so
we have 15 primary, and we
so
have
I'd have to have
93.
Sierra as my
the
okay,
primary
got it.
care, just like Kaiser. You walk in, you
Got it.
select your doctor,
Got it.
and then you have access to a complete network of specialists.
Got
All local, though. You don't have to travel to LA.
Got it.
And you don't have to travel to Orange County.
Is that going to be something that you're going to be charging on top of what the employee
No, we
already?
don't charge anything to the member.
Ah,
As a matter of fact,
good to know.
membership to our, I'm bringing a functional fitness, totally different concept. I mean, it's got ellipticals and there is some machinery in there, but it's a whole different fitness, functional for pulmonary and for seniors who aren't moving and making themselves frail because they don't take advantage. We're going to try to be proactive with a segment of the population and see if we can't get them healthier and keep them healthier.
Got it.
I think that's what all of us have been trying to do in a lot of ways, whether it's Kaiser with their Thrive program, whether it's us
Right.
trying to reach out at the primary care level, be proactive with people. It's a variant of what we're all talking about. To your CVS question, you're targeting Target. We're Providence has a relationship with Walgreens. We're starting
Right.
down in LA. It's starting to creep up towards Burbank area as well.
Mm-hmm.
This isn't, the Aetna CVS isn't a new concept for all of us, and it's a little bit of a disruptor, but it's one we've all been playing in that field for a little while as well. And I think that ultimately medical care needs to be more convenient for the patients because it's not always. I mean, the teledoc is one way to make it more convenient. But having, patients come to your office, it's not that convenient. When I have to go to the doctor, it's a pain. But, you got to do what you got to do to take care of yourself. And so finding ways. So if you're, at a place where you can get some of the easy stuff taken care of, the little coughs or colds, or get your vaccines, for crying
Right.
out loud. Doing that at a Walgreens or CVS makes total sense. And if you can integrate it like you're talking about, and we would be doing as well, so that they get their vaccine, cool, it shows up in your primary care's dashboard there. They know that this patient's already covered for this, and then it just fits into their whole rest of their care. So it's trying to reach out to the clients and find ways to access them as well. And so, you know, whether it's Aetna, with FACI, we are not, there's no FACI insurance. There's a Kaiser insurance, but we service all the different, just like this here does, we service all the different health plans except for Kaiser. And so when Aetna opens this, it means that, okay, now we've got to find a way to connect with the CVS people, whether it's Walgreens, we can do that as well. And so when Blue Shield or Blue Cross has a different program that they run out, and then we got to figure out how to adjust to that. But it's all a matter of meeting the needs of the clients and the patients where best we can. And so we're all competing, and I think the competition is ultimately
It's
good for
healthy and
everybody
good
else.
for everybody.
It's good for the clients, it's good
One
for
of
the
the other
patients. And
things that
so,
we do, to that point,
Mhm.
we bring the service as a medical provider. One of the things I do is I hook up with every kind of event I can possibly do at a senior residence or at a run. We just sponsored the run. And we will do and give free flu shots. We will do pulse oximetry. We do blood pressure checks. We do all kinds of, we don't have EKG and that portable yet, but
need that after my run.
we have, yeah, we do BPs, glucose tolerance, pulse ox, and flu shots. And we'll probably do pneumonia next that I know of. So that's another thing, bringing it to the public so that they don't have to come to the doc shop.
I think you know, another example of that is, like you said, these virtual platforms, Teledoc, you know, for the non-Kaiser Permanente patient. At our end, we call it KP Now, and we also have video visits. And we have video consults,
Right.
And so all this, and then our new offering here in Santa Clarita, with the new specialty building, it's going to be. The concept of that building is called life integration. It'll completely change how we deliver, how you see medical care being delivered. Tablets, greeters, you know, virtual check-ins. It's going to be quite, you know, it's just another way that we can provide service to our members, another more access points in a more convenient way, more affordable, higher quality. You just you focus on that, and I think the members and patients and individuals, they see the value.
Well, we were going to talk about technology too, and kind of how that's impacting and driving growth and evolution in the industry. That's one example. I mean, are there some other examples of technology and how that's improving healthcare?
Sure, I'm sure you have stuff in your practice now.
You guys are getting better. I mean, one night, because I'm part of Providence, and they have now, every time I go to the doctor, they've got something I log into.
It's called an electronic health record.
Yeah, the health record, which is kind of nice.
That's
I don't
what it
know, like, what
Well-
transpires with that, but I fill it out.
It's nice, because basically you can pull up your lab results. I mean,
Yeah.
most of the bigger groups have that, we do as well. It's now my chart, now that we're up and running on Epic here.
Right.
So we're struggling with that adjustment, and so we had some downtime for the last few months trying to
Well, let
learn
me share
Epic and
with you.
transferring over, but I think the My Chart has been very beneficial, and I find it very useful. When I get results, I get them, they show up on my phone, and it's really very quick and easy, which
Yeah.
makes it much more convenient. So that's one way to do it. And then I think there are primary care there's a lot of new products now with the Internet of Things, whether it's the scales or other things that are able to feed back. I think that'll all be an exciting thing to look forward to as we manage our patients without them always having to push that information. It just shows up.
So Steve, you asked specifically how are we improving healthcare? Well, the technology, so I'm going to give you an example, perfect example in the flu season. Where do you think it's better for a patient to access care when they have the flu? In their home or in a waiting room full of sick people, right? I mean, the answer is obvious. Traditional incentive structures for medical groups and, are to see the patient so that you can see them. But how great would it be to have an offering where the patient can call and do telehealth, those kind of appointments. So that's a perfect example where if the patient stays home and accesses care either virtually, whether it be through the phone or through a video visit, or some type of email exchange, and can provide this, same level of care. How great is that? And then so we really are improving the healthcare of a population by doing that.
And you don't have to wait.
And you don't have to wait. It's convenient.
My kid gets an ear infection in the middle of the night. I have to call the doctor. Not anymore, but I have to call the doctor. I have to wait for them to call me back. Then they send me to ER. It's the middle of the night. I'd rather just be able to say, okay, my kid has an ear infection. I've already done the compresses. It's not working. I need the antibiotic. Can you call it into the pharmacy that's open so that I can go there instead of ER, where they're just going to make me wait, and then ultimately give me that, and then I can bring my child in, at another time.
And how would you like the drone to drop the medication?
That would be great.
I think you're also.
And it will come, and it's coming.
Yeah, I think you're going to see some big collaborations with the tech industry and healthcare in probably the next decade. That's really, I think, where the opportunity lies with how to improve and really.
Well, he'll relate to this.
How we do it.
One of the big problems with HMOs, people hated them for two reasons. They had to go with the doctor, and if the doctor left the network, there was a problem. The second is getting referrals. And why is the referral a pain in the neck? Because of the time it takes. And if you're sick, or even if you're worried and not really feeling sick, you want to get that taken care of. We were 2, 3, 4 weeks with our HMO patients in various plans. It was all happening across the board. So we went to an electronic health record, and we went to an electronic referral record. We are now able to deliver a referral and are doing it, and this is conservative because I'm not using the numbers that we really use. In less than 12 hours, every stat referral is finished, is fixed, done, finished. We're really doing it in 4, but we can't publicize that. For a non-stat referral, Medicare says we have to do that in 14 days. We were able to give it within 3 to 4 business days is what's reality. We're saying between 5 and 10. That is a huge improvement. That happens in Kaiser, that's improved their referral. Now, we had a backlog, and we cleaned that all up. There was an investment that needed to be made to upgrade your systems and integrate your systems. Every single physician's office gets access to the medical record. The referral goes in, and there is an opportunity with technology under certain conditions that you can get automatic referrals, which was unheard of before. Everything was manual. So that's how technology is improving healthcare. So even HMO patients who heretofore thought that they had second-class health coverage, no longer. That's why technology is important. It's helping.
We started this conversation talking about the here and now with health. Let's finish it by talking about the ongoing crisis with opioids. What can be done to win that fight or make at least some headway in that fight?
I'm going to just start as a patient, since we've got so much, So, because I have a client that just threw me, under the bus because she couldn't get her drugs. And I'm going to say that, when I go to the doctor because I'm having a toothache or, not a toothache, let's say a jaw ache, or my back's hurting, I go to a doctor and I'm finding that they're just giving me the medication. So, I think it's going to have to, I personally believe it's going to need to start with me and my doctor. Because, as a patient, I sit in a waiting room and I wait for my appointment, and I see the little lady come up with all these drugs to the front counter, pawning off prescription drugs to the doctor to use. Now it's my turn. I go in and I'm like, okay, it's my turn. I'm here. This is my problem. Da, 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 da. Here, try this. Well, did you open up my chart? Because I think I'm allergic to that. Right? Oh no, you can try it. I go to the doctor. I have like 4 or 5 prescriptions for some of these drugs, these big ones, the big 3, Vicodin, oxycodone, and Percocet. And I don't know why they give it to me.
Change doctors.
I just really don't know why they give it to me, right? So I fill it, and I've got bottles in case anybody should need one. I fill it, but I don't ever take it. Now, I don't want to be addicted to these drugs, but my client is, and she can't get them. Why? Because Anthem caught on to it. Anthem's the first one right now that is just on it when it comes to these drugs. They will only give you a certain amount of pills for a certain amount of days, and then you're done. Someone has to prove that you still need to have them. I really believe that it needs to be me and my doctor. You know, the doctor's the one that's prescribing it for a need, for whatever that need may be. Does it really need to be this? I had both carpal tunnel surgeries last year. I got these drugs. I think I took 1 each surgery, and that was it. And I think people that are already addictive personalities are getting these, and then they just keep right on going.
So I can comment on this. I think, if you look back in the 90s and the early 2000s, physicians were mandated. I remember taking classes to the medical board where you had to treat and address pain, and if you didn't, you were there was going to be some potential risk to your license. And so, and back then there was a big push that these were great alternatives to treating pain. And so, in many ways, I don't think it came from we want to get everybody
No, I'm not
addicted. I know you're not saying that, but I'm saying that's where it started, and then now we've come full circle, right? So, I know that with Kaiser Permanente, we've adopted our safe and appropriate opioid prescribing practices where we do just what you're mentioning. There are true indications for these medications, acute surgical, post-op. There's no question that it helps. But we know that if a patient is on these medications for 10 days or more, the likelihood of addiction goes up by a few percentage points. If they're on for a month, it starts climbing. It's not a straight line. It goes up quick. And so the sooner the patients can be off these, the better. The way we do it is by education. We have to enlist the help of a multidiscipline, so all the different specialties, not just primary care. Limiting the quantities that are prescribed, creating education modules for all the providers to understand what is appropriate to prescribe for what types of conditions. Also enlist the help of other non-opiate, because patients, if I have a new patient comes to me and says, I've been on morphine for 10 years at this dose, are you going to continue it for me? And I don't like to answer that question. What I want to do is I want to tell them, I want to bring you down to a safe level, because when you're over 90 milliequivalents of morphine a day, your risk of overdose goes through the roof. And so we need to bring it down. And so we counsel the patient. We partner with other either whether they're pain management or physical medicine specialties, acupuncture. There are other ways to treat pain, not just opiates. And we also we have ways we monitor the patients. I'm going to give you an example. One of my patients who are on chronic opiate therapy, I get a urine drug screen every 6 months. We see them face to face at least once every 6 months, and we go through a drug prescribing contract that tells hey, this is what you use it for, and the plan we're going to try and bring you down, steadily bring you off of these. So it takes that level of commitment. It's a lot of work, but this is an epidemic, and fortunately we have our integrated system that helps us track that. I can quickly pull a report, which are my patients above a certain level, and I can focus on that, on that group of patients.
Yeah, those type of patients are the most difficult kind, the chronic use of them. I mean, today I prescribed 2 opioids to 2 different patients, but I also operated on both of them, so I didn't feel too bad about it. But we had that conversation. We talked about how many of these do you need, and whereas before we would have just said, okay, 30 of the Norcos,
Yeah.
run home with 15, because I looked at the procedure, said, okay, we're gonna use mostly Motrin, and you use this on top. When you don't need it, stop taking it. Because we found even with like cesarean sections, which are, it's a pretty invasive procedure, they ended up not using all their Norcos. We'd
Right.
send them home with Motrin and Norco, and you send them home with 30, well, they'd use 15. Okay, so we said, let's see how many they're using in the hospital and tailor it to that. If they're only using 2 or 3 in a day, then it's only write them for 10, 15, as opposed to just a set
30.
amount. I was 30. I was reviewing charts. Somebody not in our group, she wrote 60 just routinely. I'm like, okay, we got to stop this. So we talked about it at the next committee, and there is a education that's going on. The patient today, the one that I operate on, her husband's like, okay, so how far into this opioid crisis are we going to go, today with this prescription? So they're aware of it. They know, and they're cognizant of it as well. And so I said, this is why we're writing for how many we wrote for. So no, we don't want to go down that path, but I also don't want you writhing around in pain tonight. So it's a balance. They do serve a good purpose for a short period of time. For chronic pain, that's a tough one, and opioids are typically not the best method for it, but for acute pain, they work better than almost anything else. And so how do you find that balance without creating the addiction? I'm not jealous. The primary care guys take the brunt of that a lot of times with the long-term use of it. The short-term, specialists were able to deal with that reasonably well by saying, okay, it's going to last for here. After that, it's not my purview, because you're done with the surgical pain after this time frame, and so you're done. But we set that expectation up front too. We say, look, this is how much, and the rules have changed. Like you said before, we had to go through all this training to make sure that pain was the 5th vital sign, and all these other different things that they pushed us to really try and work on pain. Whereas now it's really more of setting expectations and saying, okay, you're going to have some pain afterwards. There's not really a lot of ways to do surgery without some pain, but we're going to make it manageable. But this is how we're going to do it, so there's not a long-term effect from it either. And so it really is an education of the patient, educating of the physicians, a re-education, because like you said, when originally they were pushing us to be very proactive with it, now it's okay, not that proactive. Back off a little bit and be very careful about it, and look at other medications. Marijuana, we're going to have to talk about at some point, because it actually works very well for a lot of different things. Are we comfortable at Facey prescribing marijuana? No. But as you find more and more patients access it for that purpose through the creams or other different ways, it actually works pretty well for a lot of different things without having the debilitating effects of the opioids, where, especially in seniors, where they're tripping, they're falling because they're stoned on the opioids, and that's problematic.
The other risk is patients that combine opiates with benzodiazepines,
Right.
which is another class of medications that we are not even talking about. There are the kind of anxiety medications that a lot of people are on. When you're on those 2 together, the risk of overdose is exponentially higher. So this is a problem, but you have to address it. You just can't let it go. But like you said, patients are cognizant of that,
They are.
and they
They're
are
much
bringing
more
that.
aware.
Now when I have that
And the
conversation,
laws
it's a little
have
easier.
changed, because you can't walk in, a pharmacy will mandate that a doctor rewrite a prescription. You just can't write a 90 or a 30-day prescription anymore. They'll take a prescription, correct me if I'm wrong, if it's written for a particular period of time and fill it for that space of time. But you can't write a 90-day prescription for
30
the
days.
opioid anymore. Is that right?
Right.
30 days.
So,
And Anthem will only fill a certain amount of pills per prescription.
right, that's what I'm talking about.
So everybody's
There is-
trying to-
There is some kind
fence
of
it in.
regulation from some of the health plans, but I think there's law. If that's what I was isn't there a law that says that the physicians are unable to write for extended periods
Yeah.
of time in one prescription?
I don't know
I
if
don't
the law, I just know it's our guideline. We just give a month at a time, no refills. So we figure out what that looks like and no refills. And if you flag above a certain level of amount,
Right.
we actually, are really on top of it. We're trying to figure out how we're going to bring
It's
it
an
down.
epidemic, it's a problem.
It is, but it's something that I think the education is helping. The patients are aware of it. We're now becoming more aware of it. We're trying to educate ourselves also on not prescribing quite so much, and not just absent-mindedly writing for what we used to prescribe, because it does have a lot of harmful effects. And the pharmacology of it, we just weren't aware of before, that it doesn't last all that long, and each time it gets a little bit shorter, but then the patient feels that need, and so it builds on itself, and it really is very addicting. So.
It's been a great conversation, and thank you again to each of you for being here. I think we could probably keep talking. There's a lot of things we still haven't talked about, but thank you very much. And now that we're all friends, I hope we can sit down and visit again in the future. But thank you again, and have a great afternoon.
Thank you.
Thank you.